to surgery, appropriate degree of TEC suppression in patient treated with differentiated thyroid cancer. Calcium management following thyroid cancer surgery or total thyroidectomy and some take-home message. So this is the classification of thyroid cancer as all are ENT consultant. So yeah, I think it's not needed to discuss with you regarding very basic things of classification of thyroid cancer. So regarding the role of addictive iodine, remnant ablation is not recommended routinely for patient with American thyroidization low risk cancer. RIA adjuvant therapy may be considered in patient with ADL low to intermediate or intermediate to high risk of differentiated thyroid cancer. Radioactive iodine is recommended routinely for patient with American thyroidization high risk differentiated thyroid cancer. In patient where the diagnosis is differentiated thyroid cancer with distant metastasis, radioactive iodine is recommended routinely after growth therapy. So previously what we have practiced is all kind of patients coming with thyroid cancer go for radioiodine, but this is not the fact. In case of low risk, there is no need for radioiodine. In case of low to intermediate or intermediate to high, when there is suspicion, in that case depending upon the clinical judgment of the physician. This is a coordinated decision by ENT specialist, endocrinologist, also nuclear medicine specialist to treat the patient whether by radioactive iodine or not. So what is the dose regarding radioactive iodine therapy following total thyroidectomy of thyroid cancer? In case of low risk, usually radioactive iodine is not recommended. But if you decide to give it, the dose is very minimum 30 to 50 millicurie. Intermediate low or intermediate to high, dose is a bit higher. In case of high risk, there is dose is 100 to 150. When there is presence of distant metastasis, the dose will be very high, 100 to 200. Treatment of non-disease and remnant or considered for ablation. So how you prepare a patient for radioactive iodine therapy? In patient with differentiated thyroid cancer, in whom radioactive iodine remnant ablation or adjuvant therapy is given, preparation for recombinant TSS stimulation is prepared about thyroid hormone withdrawal. But in our country, recombinant TSS is not much available. We use very few patients that is very high priced, imported from Thailand or Singapore or India, very high priced, very limited patient also it is imported in the wrong way. So there is a chances that it may not be correct in, or there is chances of discrepancy. So in that case, typically what we practice in our clinical practice is withdrawal of the levothyroxine. In patient with differentiated thyroid cancer with any level of significant comorbidity, that may preclude thyroid hormone withdrawal prior to radioactive iodine therapy, recombinant TSS preparation should be considered. So all high levels of ENT consultant and our teachers are here, so I request everyone to work together regarding the availability of recombinant TSS therapy, especially by any pharmaceuticals or from local industry should come with recombinant TSS therapy. But they are not interested because this is used in very limited number of patients, so they are not interested. They are interested more with the PPI and nothing else. So in thyroid hormone withdrawal is began prior to radioactive iodine therapy. What we are doing in our clinical practice, we withdraw levothyroxine for 3 to 4 weeks. If it is withdrawn for more than 4 weeks, substitution of levothyroxine can be done, but this is also not available in our country, and ideal PSA should be more than 30 before giving radioactive iodine. In patient with non-distant metastasis, either levothyroxine withdrawal or recombinant TSA should be given. Low iodine diet, although not much practice in our country, a low iodine diet approximately 1 to 2 weeks should be in, especially in patient you are planning to give radioactive iodine therapy. And low iodine diet means restriction of iodine consumption to less than 50 microgram per day. Although low iodine diet is a bit cumbersome or unpalatable, but there are some risks of developing of hyponatremia when you tested low iodine diet, especially in patients who are on the elderly or thyroid hormone withdrawal metastatic disease created with thiazide or on low iodine diet for longer than 1 week. How to counsel and minimize risk of radioactive iodine therapy side effect for the cerebral and retinal gland? Patient should be informed that there is a chances of acute or chronic cerebral gland morbidity, retinal duct stenosis, potential risk of secondary malignancy. For prevention of this, general measures include hydration are recommended. In patient with xerostomia or increased risk of dental caries, discuss regarding preventive studies with healthcare professional. Surgical correction may be needed when there is nasoretinal outflow obstruction. Counseling regarding the risk of second primary malignancy after giving radioactive iodine, especially in patient with intermediate or high risk when the dose of radioactive iodine is a bit higher. Second primary malignancy after radioactive iodine treatment, the absolute increase in the risk is very minimum and does not warrant additional screening for second primary malignancy. So this is you should inform the patient, but this is not bar to giving appropriate dose of radioactive iodine therapy to a patient of thyroid malignancy. Counseling regarding pregnancy, nursing and gonadal function. Female patient, previously we advised the patient to avoid pregnancy for the 1 year, but according to the latest American Thyroid Association guideline that is published in August 2025, they recommend at least 6 months But to be on the safe side, you can suggest the patient for 1 year definitely. Radioactive therapy should not be given to nursing female patient. Depending on the clinical situation, the therapy should be deferred until patient stop breastfeeding or pumping for at least 3 months. A diagnostic iodine 131 scale can be performed in recently lactating women to detect any breast uptake that will help you deciding whether you want to keep predictive iodine in lactating women. Male patient should be informed that when the dose is much higher, that is more than 400 millicurie, there is a chances of a potential risk of infertility. In developed countries, when the dose is very higher, they keep their sperm preserved for the patient. But in our country, although the facility is available, but a bit more expensive, and most of the patient cannot usually agree to do it definitely. But you should inform your patient that facility is available. You can keep your patient, especially when radioactive iodine dose is very much higher. Female patient receiving radioactive iodine therapy should be counseled that such therapy has not been shown to impact future partner. So in case of female, there is no ovarian impairment, but in case of male, there is a chances of sperm quality destruction or aberrant abnormality, or there is testicular dysfunction. So regarding the classification of clinical response to surgery, according to the latest AT, like an excellent response, intermediate response, biochemical incomplete response, and structural incomplete. So as all ENT professors here, so I am not think it's going to be much. This is needed because I will show you how TSH should be targeted. So that depends upon this classification. So excellent response when the post-total thyroidectomy neck dissection with radioactive iodine therapy, when non-stimulated thyroglobulin less than 0.2, stimulated thyroglobulin less than 1, and negative imaging. And when there is without radioactive iodine adjustment, when thyroglobulin is less than 2.5, TSH should be kept within reference range. In case of intermediate, also TSH should be kept within reference range. But especially when there is biochemically incomplete response, that means there is higher TC or higher antibody level, in that case TSH should be kept below normal references. Also in case of structurally incomplete cases, you should keep TSH below target range. So when the response is excellent, in that case you should keep, or there is low risk, you are not giving radioactive iodine, in that case TSH should be kept within normal limit. Normal range of TSH is 0.5 to 2, you just keep FT4 and TSH within target. But when there is biochemically incomplete response or structural incomplete response, only in those two kind of patients you should keep your TSH suppressed. So what is the appropriate degree of TSH suppression in patient treated with differential cancer? This is an individualized decision to initiate TSH suppression to below the reference range recommended based on potential benefit and risk, recognizing that patient with high risk is more likely to benefit from the TSH suppression. Long-term TSH suppression is not suggested in case of low or intermediate risk disease when there is no evidence of biochemical or structural recurrence. Risk versus benefit of TSH suppression and TSH growth should be reevaluated over time, because there are some adverse effects you suppress TSH, especially there is a chances of angina, ischemic heart disease, atrial fibrillation, stroke, cardiovascular mortality, increased risk of osteoporosis, and possible fracture, especially in case of postmenopausal women. So what we see in our clinical practice till now, irrespective of patient comes to us with a history of thyroid cancer, go for radioiodine and keep the TSH very suppressed. This is our usual practice. But what's the recent recommendation? This is published after 10 years from 2015 to 2025. In all kind of patients, there is no need of TSH suppression. TSH suppression needed only structurally incomplete or biochemically incomplete. So in this kind of patient, you should keep your TSH suppressed. But you should think the patient regarding the assessment of whether we will get more benefit by TSH suppression or keeping the TSH in the normal range. Whether there are any chances of age of the patient, there is chances of osteoporosis, chances of atrial fibrillation, any kind of age the patient is, you should clinically judge the patient whether you should keep your TSH suppressed. So this is the individualized decision to be made on individual basis depending upon the risk factor of the patient. What is the target level for the specific TSH patient? So routine TSH suppression you should get out of it. Regarding calcium management following thyroid cancer surgery or total thyroidectomy, development of acute hypocalcemia after thyroid surgery lags behind before the decline in PTSA, and the patient has been discharged before the hospital, before calcium reached a nugget which may occur 24 to 72 hours after thyroid. So just after thyroidectomy, it takes time. If you remove parathyroid, it takes time to parathyroid hormone to come to low. It may come low a bit after 24 to 72 hours, but due to advanced surgery, surgeon like to discharge the patient maybe within 1 or 2 days. So patient may have hypoparathyroidism, but it may not be evident before the discharge of the patient. Therefore, it is important to anticipate the possibility of progressive hypocalcemia and should take necessary steps to institute and prevent development of hypocalcemia. An empirical prophylactic approach should be done in our settings because there is a doing PTS levels that was not available in all the hospitals. Also, if you send PTS, the report will come after 2 or 3 days. Also, regarding the checking of the calcium. So, empirical approach should be, or we should give oral calcium 500 to 625 to 1000 to 12,550 milligram 2 or 3 times daily with calcitriol 0.5 to 0.1 gram daily without doing calcium and PTS. This should be routinely given to all kind of patient after doing thyroid surgery. This aggressive approach where we are treating the patient with calcium and vitamin D without checking PTS and calcium level, there are some minimum risk of hypercalcemia, also deterioration of the renal function, but still it is more appropriate steps in our settings because we just start calcium and vitamin D, ask the patient to consult with the endocrinologist say for 7 or 2 weeks later, then endocrinologist will check the thyroid function test and reduce or taper or discontinue calcium on PTS level. So in case of mild to moderate hypoparathyroidism, when PTS is less than 15, calcium less than 8.5, ionized calcium less than 1.1, you should think of giving post-oral calcium supplementation. When the patient is progressive hypoparathyroidism or symptomatic hypothyroidism or calcium less than 7, you should also check magnesium level. Especially after thyroid surgery or parathyroid surgery, it is good to add magnesium level. Magnesium is available in our country. 325 tablets, you can give 2 or 3 tablets. Later, after checking magnesium level, you can discontinue. Otherwise, patient may develop hypocalcemia with tetany. The long-term management of hypoparathyroidism aim to maintain serum calcium within asymptomatic range, avoid significant hypocalcemia or hypercalcemia. In order to minimize the risk of symptoms, serum calcium should be maintained in no lower range, and serum phosphorus should be maintained no higher than upper. So calcium should be maintained in the normal range along with phosphate. With phosphate a bit upper end of normal, with calcium a bit lower end of normal. But this also depends upon the symptoms of the patient, what kind of symptom patient is complaining. So this is the dose recommended by American Thyroid Association in their management of post-operative hypothyroidism paper that is published in 2018. Empirical prophylaxis, you should give calcium 2 or 3 times daily with calcitriol 0.25 or 0.5 milligram 2 or 3 times daily, 2 times daily. In case of mild to moderate hypoparathyroidism, calcium carbonate along with calcitriol should be given. When there is progressive and symptomatic, you should better give IV calcium 1 to 2 gram calcium carbonate followed by continuous IV infusion. Sometimes the tetany or hypocalcemia is so much evident that you should continue IV infusion of calcium, say for 5 or 10 ml of calcium carbonate in 1000 ml of normal saline or DA for 1 or 2 days. Later, you should gradually taper and discontinue calcium, or usually you can maintain up to when you are confident that the patient parathyroid has been now successful. There is a term parathyroid staining. When the surgeon do the operation, parathyroid is handled, that this is done, no hypothyroidism, but due to staining, the patient develops hypocalcemia and tetany. But after 2 to 3 weeks, you will see that without calcium, patient maintain normal calcium level, also PTS become normal. So I have seen 3 things here regarding the endocrine roadmap: radioactive iodine, TSH suppression, and calcium replacement. So take home message for my today's presentation: a structured endocrine roadmap ensure continuity of care after thyroid cancer surgery. Risk-adapted follow-up of thyroglobulin and imaging enable early detection and intervention. TSH suppression should be individualized to balance cancer control and overall health. So this is very important regarding the TSH, especially in the setting of osteoporosis and atrial fibrillation. And molecular insight and precision approach refine prognostication and treatment decision. And long-term patient-centered follow-up promote both endocrine stability and quality of care. So this is the collaboration between the ENT surgeons and endocrinologists to keep the patient good endocrine health, especially after endocrine surgery. Thanks and gratitude to National Institute of ENT. Our sincere pleasure and thanks to all the ENT specialists on behalf of Bangladesh Endocrine Society. Special thanks to Professor Abdul Kohen Mithu sir to invite me to deliver my presentation. Also to you, Director Hassan Jafari sir. And thank you everyone for your attention. Cancer is a word, not a sentence. And we should always work together with great empathy to thyroid cancer patients to make them a good and healthy life. Thank you so much for your kind attention. Thank you so much.